Kinematics, kinetics, the gait cycle, stance and swing phase. All of these terms are associated with walking or gait. This video is the second in a series on walking. The first video dealt with normal gait. This video will examine walking impairments or pathological gait as it specifically relates to cerebral palsy. Before you can understand pathological gait, you need to understand the basic principles of normal gait. Let's begin with a quick review.
Normal walking has 5 attributes: stability and stance, foot clearance and swing, pre-positioning of the foot for initial contact, adequate step length, and energy conservation.
Neuromuscular conditions such as spastic cerebral palsy or CP alter those prerequisites and change the kinematics and kinetics.
Therefore, the 5 attributes of normal walking are frequently impaired. Stability and stance is challenged by 2 factors: an abnormal foot position which creates an unstable weight-bearing surface and/or compromised balance caused by lack of trunk and lower body motor control. Clearance in swing is challenged by inadequate hip and/or knee motion or insufficient ankle dorsiflexion. Appropriate pre-positioning of the foot for initial contact allows for efficient energy transfer between body segments. It is compromised by inadequate foot positioning in terminal swing. Adequate step length, including a means of progressing the body forward, can be hampered by inadequate knee extension in terminal swing, an unstable foot on the stance side, or inadequate plantar flexor push-off from the stance side. The 5th attribute is conservation of energy. Of all the prerequisites for normal walking, energy conservation and its measurement actually encompasses and measures the total deviation of the other 4 prerequisites. The key to efficient gait is energy conservation. Walking is a constant interplay and transformation between kinetic energy and potential energy. When a person is compensating for a gait deviation, the transfer of energy is less efficient and more energy is used. We notice when people do not walk like we do, but have difficulty identifying what is different. Understanding the mechanisms of how and why walking is different in conditions such as cerebral palsy helps to devise a plan for treatment which will ensure optimal results. Tools like gait analysis are used to accurately identify the problems and choose the best treatment solution.
Cerebral palsy, or CP, is a collection of disabilities of disordered movement caused by an injury to the immature brain. The injury can occur before, during, or after birth.
The injury does not damage the child's muscles or nerves, but only the brain's ability to control them. A spectrum of disability exists from very mild to very severe. Deviations in the mildest cases usually occur distally in the limbs. As severity of the disability increases, deviations become more proximal.
Classification of cerebral palsy is usually based on both the location of the injury and the parts of the body affected.
Injury to the pyramidal system results in spastic CP. Injury to the extrapyramidal system, or the cerebellum, results in athetoid or ataxic CP. Damage to both systems results in a mixed type of cerebral palsy.
Extent and location of the brain injury determines the body parts affected. Not only limbs and trunk can be affected, but speech, sensory organs, cognition, and other systems can be affected as well.
Location of motor involvement leads to further classification. In hemiplegia, one side of the body is affected, including both the arm and the leg. The face and trunk can be affected as well. Gait analysis has been used to subtype hemiplegia into 4 categories based on the severity of involvement of the lower extremity. Each type has specific characteristics that are useful in planning treatment. Diplegia refers to primary involvement in both legs with lesser involvement in the arms. Many children who are born prematurely have this type of CP. Triplegia includes involvement in both lower extremities and one upper extremity. The location of injury in triplegia includes a primary motor strip injury often seen in hemiplegia, in addition to the injury that leads to diplegia. In quadriplegia, all 4 extremities are affected. Children with spastic quadriplegia have more global involvement and many are unable to walk.
As a direct result of the brain damage, common features of abnormal movement are present across all types of cerebral palsy.
These primary impairments include abnormal muscle tone, loss of selective motor control, impaired coordination and balance, weakness, loss of sensation.
Secondary impairments, which are not the direct result of the brain damage, also contribute to impaired movement and walking.
Abnormal tone, for example, creates abnormal muscle forces and an imbalance of those forces. In a growing child, over time, abnormal muscle forces can lead to muscle tightness and contracture. Bony deformity is another secondary impairment associated with abnormal tone. Abnormal muscle forces on a growing skeleton can result in alterations in formation and growth. The loss of selective motor control affects the function of muscles which span 2 joints more severely than single joint muscles. 2 joint muscles are very important in walking. If a muscle controls 2 joints, the timing and intensity of contraction has to be very precise if the muscle is to work appropriately. When motor control is impaired, the timing, intensity, and coordination of the muscle activity is affected. Problems with balance and coordination often result. Weakness is a primary impairment that is present in varying degrees in children with CP. Sensory impairments, including decreased proprioception, is also a primary impairment. Loss of sensation is most evident in the upper extremity of children with hemiplegia.
Poor motor control not only affects the timing and coordination of muscle activity, but their growth as well.
Muscles grow in response to stretch. In simple terms, a child gets up in the morning and her bone has grown slightly from the day before. As she runs and plays during the day, the muscles which span the bone are stretched. It is this stretch, in conjunction with the presence of growth hormones, which signals the muscles to grow in length by adding sarcomeres at the musculotendinous junction. Children with CP are unable to move through the entire joint range of motion repetitively, and the muscles are inadequately stretched to stimulate the typical amount of growth that would otherwise occur.
As mentioned, muscle forces and timing and control are abnormal in CP. However, we often fail to realize that the bony lever arms, which are the moment arms upon which the muscles act, are often abnormal as well.
As discussed in normal gait, a moment is a force acting at a distance from an axis or rotational center causing the body to rotate. It is best illustrated by 2 children on a teeter-totter. A lighter child can balance a heavier child with no net moment or rotation produced if the lighter child sits further from the axis. The formula for this is Cm times d equals Cm times d. Abnormal muscle forces combined with the lack of normal growth stimulation alter a bone's growth both in shape and orientation. A child's bone is genetically programmed to grow. The rate of that growth depends on a variety of factors including physiological stresses, nutrition, and the presence of growth hormones. The bones have a pre-programmed blueprint for shape, but the blueprint is also dependent upon the magnitude and direction of internal muscle forces and external ground reaction forces which act on that bone.
In CP, abnormal muscle forces, lack of normal movement and/or weight-bearing, disuse, and compensatory mechanisms can alter the bony lever arms. This is often referred to as lever arm dysfunction.
4 different types of lever arm dysfunction are commonly seen. These include malrotation, loss of a stable fulcrum, loss of bony rigidity, shortening of the lever arm. If a bone becomes rotated abnormally, its effectiveness as a lever is decreased because the position of the forces acting on the bone in relation to the joint's center is changed. These can be either muscle forces or ground reaction forces. In either case, power generation and movement generation are lost. An example of this would be external tibial torsion. The external rotation of the tibia places the foot external to the direction of forward progression. The ground reaction force vector moves posterior and lateral from its normal position relative to the knee. This results in loss or reduction of the normal knee extension moment. In addition, valgus and external rotation torques are introduced, which create further lever arm dysfunction and increasing difficulties with ambulation. Hip subluxation results in a loss of a stable fulcrum because the femoral head is not completely covered by the acetabulum. Normally, the stable axis of the femoral head in the acetabulum creates a fulcrum from which the femur can pivot. When subluxation or dislocation occurs, the stable pivot point upon which the internal and external moments of the femur can act is impaired. This results in poor abductor muscle control. Abnormal gait mechanics such as Trendelenburg limp or excessive upper body motion are often present in order to compensate for the weakness. An example of loss of bony rigidity is pes valgus.
This is the normal bone orientation in the foot. In pes plana valgus, this normal orientation is lost, and a subluxation of the talus on the calcaneus occurs.
During normal gait, the foot acts as a lever arm in terminal stance when the heel comes off the ground by becoming a rigid structure. This allows gastric soleus contraction to propel the body forward. With pes valgus, the loss of rigidity creates a situation not unlike trying to lift up a stone with a rubber crowbar. A simple example of lever arm shortening is coxa breva of the hip, where there is a true shortening of the neck of the femur. Another example is coxa valga, where the neck shaft angle of the femur is increased. The effect in either case is a reduction of the distance to the center of the hip joint. The magnitude of the moment the hip abductors is able to produce is equal to the force the muscle generates times the perpendicular distance to the center of the hip joint rotation. In coxa valga or coxa breva, despite the fact that the muscle force is normal, the moment is reduced in direct proportion to the reduction of the length of the lever arm. When the moment is decreased, the power which can be generated or absorbed is also reduced in direct proportion to the length of the lever arm. Lever arm dysfunction can be the source of many gait deviations in CP.
There are other types of abnormalities often present in the gait of individuals with cerebral palsy. These are referred to as coping responses.
Coping responses are movements which are used to compensate for the primary and secondary impairments in order to maintain function. For example, this child uses upper body shift to compensate for hip abductor weakness. Without the primary and secondary problems, coping responses would not be necessary. While they are functional solutions to the problems associated with walking, they usually increase energy expenditure. All gait problems, whether primary or secondary or coping responses, result in excess energy consumption. Energy expenditure increases with severity of involvement and whether or not assistive devices are used. Based on research conducted at Gillette Children's Hospital, 80 to 85% of all children with cerebral palsy have energy costs which are above 2 standard deviations of normal, or beyond the range of typical energy expenditure for all children without disability. Children with the mildest hemiplegia expend on average 10 to 30% more energy than normal children walking at a similar velocity. Children with spastic diplegia who walk without assistive devices expend on average 75% more. Children with quadriplegic forms of cerebral palsy expend the most energy to walk for daily activities. Those who walk independently expend about 90% more energy than those without walking problems. The use of assistive walking devices increases energy expenditure even further, and walking speed is much slower. Consequently, children with diplegia who use assistive devices expend 105% more energy on average than their peers without walking problems. That's more than twice the normal amount of energy. Children with quadriplegia expend on average 130% more energy if they use assistive devices. To put this into perspective, 100% more energy is equal to the energy a person expends walking up or down stairs. That's twice as much energy as is used when walking on level ground.
We're now ready to briefly review the normal function and pathology of each of the major lower extremity joints. We'll begin at the foot and ankle. Deviations at the foot and ankle can be divided into 3 categories.
Deviations caused by excessive plantar flexion, excessive dorsiflexion, or deviations caused by bony deformity. Excessive plantar flexion can be caused by anterior tibialis weakness, gastrocnemius or soleus tightness, or overactivity, or a combination of weakness, tightness, and overactivity between the 2 muscle groups creating imbalance. Consequences of excessive plantar flexion during stance phase affect primarily initial contact and mid-stance. Loss of forward progression, shortened step length, and loss of stance phase stability with increased excursion of the center of mass can all occur. Increased plantar flexion at initial contact creates a loss of first rocker at the ankle. Consequently, the individual enters the gait cycle with either a foot flat position with knee extension or toe contact with knee flexion. Sometimes with anterior tibialis weakness, loading response does occur but is poorly controlled. This results in the common foot slap gait sometimes seen in children with hemiplegia. The most common stance phase error at the ankle caused by excessive plantar flexion is an excessive plantar flexion knee extension couple. In normal gait, during second rocker, the ground reaction force falls in front of the knee and in front of the ankle, creating knee extension and ankle dorsiflexion. Action of the ankle plantar flexors controls the position of the ground reaction force. The plantar flexion knee extension force couple stabilizes first the knee and later the hip. Because of the excessive plantar flexion in cerebral palsy, the normal first rocker is absent. As dorsiflexion is attempted with the foot flat, the ground reaction force is already in front of the knee, creating knee extension. Because the gastrocnemius is stretched prematurely at both ends of the muscle, it contracts prematurely. On the motion graph, this is seen as a characteristic double bump pattern of increased dorsiflexion followed by decreased dorsiflexion. This is repeated again in terminal stance when the muscle is stretched a second time. With plantar flexion, the ground reaction force moves further anterior and knee hyperextension results. Many times this knee hyperextension during mid-stance is thought to be caused by hamstring weakness, when in reality the cause is plantar flexor tightness.
Excessive dorsiflexion and deviations caused by bony deformity and muscle imbalance are the other deviations at the foot and ankle.
Excessive dorsiflexion is most often caused by lever arm dysfunction or superimposed iatrogenic weakness from lengthening of the heel cord in the presence of overactive hip flexors and/or overactive hamstrings. If the soleus is weak relative to overactivity of the hip flexors and hamstrings, the foot will dorsiflex excessively and a crouched gait pattern will result. In normal gait, by retarding second rocker and moving the ground reaction force in front of the knee, the soleus acts to assist knee extension. If the gastric soleus tendon is lengthened without regard to contracture or spasticity in the hamstrings and/or hip flexors, the weakened soleus will no longer be able to restrain forward advancement of the tibia, and the function of the normal plantar flexion knee extension couple will be impaired. The ground reaction force falls behind the knee and in front of the hip and ankle, increasing the flexion moment at all the joints. The lengthened heel cord becomes over-lengthened with time because of weakness and continuous stretch. When this happens, quadriceps muscle activity is required to prevent collapse of the knee. This in turn necessitates an increase in energy cost. During terminal stance, a loss of heel rise occurs and less power is generated. This loss of energy and momentum further impairs swing phase knee mechanics.
The third stance phase deviation at the foot and ankle complex is malrotation, caused by varus or valgus foot deformity.
Malrotation can occur with either excessive plantar flexion or excessive dorsiflexion. They include either eversion or inversion of the hind foot as well as multiple forefoot deviations, most of which produce what often is referred to as lever arm disease. At initial contact, the malrotation causes an abnormal load on the muscles which control the inversion-eversion forces, and stance phase instability results.
The typical malrotation which occurs is different depending on whether the child has hemiplegia or diplegia. But the primary imbalance in both cases is equinus of the foot, secondary to overactivity of the triceps surae. Usually only the gastrocnemius portion of the triceps is involved, but gastrocnemius and soleus overactivity can occur, particularly in hemiplegia.
The child with hemiplegia generally has overactivity in the posterior tibialis muscle in conjunction with overactivity of the triceps. Consequently, the calcaneus is pulled into equinus and inversion, which creates hindfoot varus. The talus is forced lateral and superior to its normal position, and the forefoot is positioned in adduction. The midfoot is in relative cavus. Children with diplegia or quadriplegia tend to have valgus deformities because of overactivity of the peroneus brevis in conjunction with the overactivity of the triceps surae. The calcaneus assumes an equinovalgus position. Consequently, the talus rotates medially and inferior and drops off the sustentaculum tali. The orientation of the bones of the midfoot is also disturbed. The forefoot goes into supination and abduction. With either varus or valgus deformity, loss of stance phase stability is imposed.
Other problems are present in swing phase. These can be seen in the foot, ankle, knee, and hip.
The major swing phase deviation at the foot and ankle is excessive plantar flexion caused by relative weakness of the anterior tibialis musculature. The result is foot drop, or toe dragging. Occasionally, toe dragging is caused by inadequate knee flexion during swing phase, which the ankle cannot compensate.
When disorders are present at the knee, the problems are consistent across all types of cerebral palsy. Errors at the knee are primarily limited to flexion-extension errors, but rotational errors can also occur because the femur is twisted out of the plane of progression. The errors in stance phase are usually abnormal position, malrotation, or both. Errors in swing are associated with inadequate range of motion and weakness.
Excessive flexion is probably the most common error present at the knee during stance phase. The flexion deformity is usually secondary to relative overactivity of the hamstrings, although flexion deformity at the hip or plantar flexor weakness at the ankle can also produce this deformity. Regardless of how the deformity comes about, the knee flexion drives the ground reaction force posteriorly. This reduces or prevents the normal knee extension moment. With knee flexion, the ground reaction force falls behind the knee instead of in front of it. The knee will collapse into further flexion if the quadriceps and/or hip extensors do not produce an adequate extension moment to balance the ground reaction force. However, increased muscle action means more caloric energy is required to walk.
The excessive forces generated by this crouched walking pattern can also lead to chondromalacia and osteoarthritis of the patellofemoral joint.
Malrotation of the femur and tibia also contributes to stance phase errors at the knee. Internal torsion of the femur with external torsion of the tibia is a transverse plane abnormality which is often mistaken as a coronal plane abnormality because of the visual appearance of knee valgus. Because of the position of the ground reaction force, additional stresses are placed on the ligaments of the knee.
Therefore, it's important to identify this deviation as a rotational deformity to assure proper treatment.
The most common swing phase error at the knee is decreased motion. Spasticity in the rectus femoris and hamstrings contributes to loss of the timing and control required for normal swing phase mechanics at the knee. Children with cerebral palsy often use the rectus femoris to augment hip flexion. Because of its prolonged action, the rectus femoris functions at the same time as a knee extensor. Loss of swing phase knee flexion occurs as the rectus femoris and hamstrings remain active throughout swing and a stiff-kneed gait results.
Unlike the knee and ankle, the hip is a ball and socket joint with 3 degrees of freedom. Gait abnormalities at the hip, therefore, can and do occur in all 3 planes.
In the sagittal plane, excessive hip flexion can be caused by spasticity of the hip flexors, weakness of the hip extensors, or can be secondary to excessive knee flexion and/or ankle dorsiflexion. Excessive adduction is commonly noted in the coronal plane because of adductor tightness and/or abductor weakness. Malrotation in the transverse plane is usually caused by bony deformity, but may be secondary to overactivity of the internal femoral rotators.
In cerebral palsy, the hip flexors, adductors, and internal rotator muscles are usually overactive relative to their antagonists. Because of this muscle imbalance, weakness and lever arm dysfunction, abnormal bony position can result, and there is inadequate power generation. Compensatory mechanisms to circumvent this weakness are often identifiable and increase energy costs.
The child is forced to use weight shifts of the upper body to compensate for the imbalance which is present. Examples include a Trendelenburg lurch to compensate for abductor weakness, circumduction to compensate for inadequate hip or knee flexion, ankle plantar flexion, or excessive internal hip rotation.
In conclusion, we can see that the primary and secondary impairments associated with CP disrupt the attributes of normal walking. The bony deformity, imbalance of muscle activity and weakness, and impaired control all contribute to the deviations seen. Fortunately, our bodies automatically compensate for the disruptions, and allow maintenance of upright walking as much as possible despite increased energy costs. Goals for treatment are to make the child's walking as efficient as possible within the constraints of the primary damage that has occurred.
Understanding how gait can be affected by cerebral palsy is the first step to understanding treatment options for the child with CP.